Welcome to the Digital Healthcare Experience. I'm Naomi Schwimmer with Taylor Healthcare. Thank you for joining our discussion today on people, process, and platform, physician perspectives on informed consent. All attendees have video and audio turned off. So if you have a question for our panelists, we will be monitoring the chat and we'll set aside time at the end for Q&A. The session is being recorded, so we will be sure to share that with you afterwards. And we'll also let you know when our next registration is open for the Q3 panel discussion. All right, so why are procedural informed consents very often the last workflow to be digitized in healthcare? Well, this is not just a document, it is a process. And so this kind of systemic process change can often require special consideration for addressing the complexity and nuance of conversations that are taking place across the entire health system, in every doctor's office, every hospital room. So it is, is a lot of complexity involved. And we will hear today from two physician leaders who have taken on this challenge at their health systems. So full disclosure, both have implemented Taylor Healthcare's iMed consent solution, but our conversation today will be focused on general insights that can benefit anyone interested in digitizing this process at their health system. And now I'd love to introduce you to our panelists. First, we'll start with Dr. Coster, Medical Director of Perioperative Services at Inova Health System. Dr. Coster was elected as president of the medical staff at Inova and previously served as the Department of Surgery chairman at Alexandria Hospital. While serving as the president of medical staff, Dr. Coster was instrumental as the physician lead for the initiative to digitize Inova's informed consents across their health system. And Dr. Fink, Professor Emeritus at the Emory University School of Medicine, currently serves as Taylor Healthcare's Chief Medical Officer. And Dr. Fink was also Chief of Surgical Services at the Atlanta VA Medical Center for 16 years. He was also the governor of the American College of Surgeons for 6 years and lead surgeon for the VA Southeast Network for 3 years. Dr. Fink has led the largest randomized controlled trial conducted to date on informed consent. Surgical informed consent. And now on to our moderator, Doug Stefano. Thank you.
Great, thanks, Naomi. Welcome, everybody. Today has a decidedly impactful Philadelphia flair, I just learned. So Dr. Coster is a University of Pennsylvania grad. Dr. Fink went to Franklin and Marshall, and I am a descendant of family born and raised in Philadelphia. So this is a very East Coast slant today, but hopefully you still listen in and learn something. So to get started, Dr. Fink, let's start with you. Can you tell us a little about or provide some context around your time at the Veterans Administration and why you wanted to digitize informed consents?
My pleasure, and thank you both for allowing me to join you today. I hope you're hearing me okay.
Wonderful.
Okay, perfect.
Yes.
So the discussion really on this point goes back to really the turn of the century or even before. And there were three major factors that certainly I wasn't the one who initiated this, but it came out of big central VA headquarters. But there were major concerns that focused on three issues. First and foremost, major concerns about inadequacies of the informed consent process, particularly since they perceived it to be a mechanism by which patients would be appropriately informed. Now, some of the evidence that raised these concerns was a big study run by a lady named Melissa Bottrell, who published her findings in 2000, actually, where she did a review of volunteered procedural informed consent forms from about 500 and something hospitals. She accumulated a total of nearly 600 consent forms and reviewed them extensively with all kinds of formal protocols. And to her, not surprising, she found that only in 26% of those over nearly 600 documents were the four what they deemed to be critical elements: procedure description, benefits, risks, and alternatives included in the document. Raised really major concerns about that. Ironically, our chief of surgery at the VA hospital in Atlanta, when I was serving there, was also interested in this, and he ran a similar, much smaller scale study, but looked only at transurethral or sexual prostate, TURP, or radical prostatectomy, and found basically very similar findings when he accumulated the consent forms over 5 years at our hospital, that about 40% at most had those critical elements. So clearly there were perceived deficiencies, at least in the documentation. Now, there was a lot of other literature that discussed the fact that, or documented major concerns about lack of comprehension or understanding on the part of patients. That was another element. So that was one of the major focuses. The second was an interesting study published about the same time in legal literature, which looked at the experience with what they call tort claims or malpractice claims in the VA. And this study was published by a gentleman named Weeks, and he found, let's see, it was from 1984 through the year 2000. And he found that on average, over that period of time, the VA had paid $555 million in tort claims, which was an average of about, let me look at my numbers here, $46 million a year. In addition, there was an $11 million expense per year approximately for legal expenses. So that was a huge expense, let alone the concern that many of these may have been related to informed consent. When they looked at when he looked at the data, only 2.7% of those cases was a lack of informed consent, the primary reason for the tort claim. But when you add up the payments and the legal fees, that still came up to about $1.6 million a year. So that was a big financial incentive as well as legal. And the other concern related to finances particularly was, one, the fact that there was a major cost associated with taking paper documents and scanning it. And one investigator in the VA did a study of 3 VA hospitals, came over an average, and this was what, 20 some years ago, of $80,000 a year just for the scanning. And then lastly, the concern about misplaced consent forms, which led to major delays in the operating center. Again, another loss of funding. So I think there was a multitude of reasons that really propelled the initiative to get the VA to move forward with informed consent.
Awesome. Thank you so much. I guess our taxpayer money, I know where that's going now to cover all those tort claims out at the VA, but
not anymore.
Not anymore, right? Not anymore, exactly. So, I think we hear on the, pretty regularly in the market, like, well, it's the VA, you can do it, it's all, centralized. So Dr. Coster, we'll go to you. Why did you choose to do it at Inova? What did you try and solve, and why was it important for the health system to, implement a digitized informed consent process?
Sure. Thanks, Doug. And thanks, Naomi, for having me on this panel. So this actually came about out of necessity. We were actually during a JCO at one of our our largest hospital, our biannual review, were found to be horribly consent deficient. They happened to pull a chart on a lung transplant and there was no surgical consent. So immediately the red flags went up and they brought in an ad hoc committee because JCO said, what's your action plan going forward? Because you got to fix that. And we actually went into a deep dive, and it's interesting that Dr. Fink brings up 26%, because when we looked at our consent compliance, when we did a retrospective review of 2 months, we were only 18% consent compliant with the factors that we needed to be compliant for JCO. So they wanted an action plan, and part of that is how we were going to solve it going forward. And of course, we talked about education of surgeons, et cetera, et cetera. They really didn't like that until we came with, we're going to digitize our process so we're 100% consent compliant all the time. The other issue we had is actually we have 5 hospitals and multiple outpatient settings, and everyone was kind of doing it a little bit differently. So we had a informed consent process that hadn't been looked at for years. So we kind of had to go back and build it from the ground up, and first do with Taylor on board, but first do our consent process and what that looked like and make sure it was going to be acceptable to all parties, including the outpatient facilities, who at that time were having anyone sign consents who could basically forge a signature. So basically, you know, necessity is the mother of invention, and that's how this kind of bore this out. It was very interesting because we had no idea the deficiency was so dramatic, but it was deficient in the teams across all 5 of our hospitals and outpatient centers. So it definitely required immediate action.
Great, thank you. So, you know, we hear frequently from hospitals that implement our systems that there's always a barrier or a challenge, right? And I'm sure both of you have experienced the same. So I'd like both of you to weigh in on this. Tell us a little bit about the biggest barrier or challenges that you faced and how you overcame it. And Dr. Fink, I'll start with you.
Well, there's no question that changing work habits is always difficult for any group of individuals. And it's probably as much or more so for surgeons, I would say, from years of experience. So clearly the 2 biggest and most difficult part from my perspective was getting buy-in from the people who would be doing the informed consent process suddenly changed, and also training about the new system. Now, out of fairness, of course, the VA has one of the most robust, or at least it did have one of the most robust electronic medical records systems, and that had been in place since the mid-1970s. So there was at least a tradition of digitization of healthcare processes already. So it was a little bit less of a leap for some than others. But that was clearly the hardest part, to get buy-in and people willing to take it on and be compliant. In terms of how we try to address some of those things, when the system was mandated by the VA in 2004, purchased and then mandated to be implemented in every VA hospital, every outpatient facility for any informed consent process, that helped, because the VA, being the way it is, a national organization, they can make mandates, and allows them not only to do that, but to make it a performance metric, if you will. So that was one thing that helped. It didn't necessarily create smiles on people's faces, but it certainly helped with targeting and gave the people who were trying to implement it a little bit of more power. But the way we tried to do it was we tried to do it in a way that made a lot of sense. First and foremost, we didn't try to do it all at once. We picked what we thought might be an easy surgical section and rolled it out one section at a time. And we ensured that when we were beginning our rollout, be it one section or ultimately through the whole service, was to have a dedicated project manager with committed IT support always available. And I think those were the 2 things that I think really helped us be successful. And lastly, of course, there was, I could call another VA hospital and say, how are you doing? What suggestions do you have? That is, I think, another thing that can now be pursued given the prevalence of electronic systems.
So give us the answer to the test. The whole audience is waiting. Who got selected as the first group to go on board?
We actually chose ophthalmology.
Ophthalmology, all right.
Yeah.
Interesting. Not urology. You want ophthalmology.
Not urology.
Okay. Interesting. All right. Well, there you go. Everybody on the phone that's trying to learn, start with ophthalmology. It makes it a lot easier. Dr. Coster, how about you at Inova?
So we kind of did a similar thing, but we didn't do it by specialty. We did it by size of hospital.
Okay.
So we chose our smallest hospital, about 220 beds, and launched that first. And what we basically did is we needed champions, and we picked really involved, not only people from the medical staff, but also strong leaders within the nursing staff to help promote this. And that seemed to work pretty well by going. And what we did is we had a week-long launch where we had multiple people on site. I mean, our team was actually very small. We only had 8 or 9 people to implement this across the system. And then we went from hospital, we launched a hospital per month. And not until we got everyone up online did we shut off. And then we went 3 months later and then shut off all paper consent. So we kind of slowly, Chinese water torture, so to speak. We did, of course we got pushback, like Dr. Fink said, terminally degreed people are sometimes difficult to convince that there is a better way to approach things. And I think part of that is just familiarization with the product and the workflow and the process. I mean, I can click 4 or 5 buttons a lot harder than I can illegibly write a procedural consent. And I think once people had some experience with it, they were very quick to adopt it. But I think, again, it's the unknown. It's kind of like doing anything new. It feels unfriendly. I mean, I do think we had a little more difficulty with older practitioners who tend to not be as technologically savvy, but this is not a technologically heavy process. So I think once they saw it and experienced it, it was a pretty easy adoption.
So I'm assuming you started with Loudon. Was Loudon the smallest hospital?
No, Mount Vernon Hospital.
Oh, Mount Vernon. Sorry.
Yeah.
Sorry. So would a physician that was using it in Mount Vernon also provide services at another hospital and then go back to paper? How'd that go?
No, we were
Once
we turned it on to everyone. But
okay.
But what we did is we rolled it out at Mount Vernon, for instance, the first week, and then Alexandria Hospital a month later, and so on and so forth around the Beltway.
Okay, gotcha. Awesome. Thank you so much.
So,
So,
Doug,
go ahead, Dr. Fink.
I would also point out, it's also important to remember that as much as we hate to admit it, there are times when an electronic system can crash. And if it does, one has to, of course, resort to something. So one of the other things that was reassuring, at least to the providers, is that, well, we can always go back to paper if we have to. And of course, that was a big thing in the VAs with such a long experience about what one would do. Actually, it was mandated in memorandums about what you had to do if the system crashed, but it certainly applied to the informed consent as well.
Great. Awesome. Good input. Thank you. So we get there's some benefit here for the health system. You guys captured it nicely. Can you talk about the benefit from a patient care standpoint? And Dr. Coster, I'll start with you if you don't mind.
So I think the first thing is the one thing that I think from a patient care standpoint, from a provider point of view, is these are standardized consents. So when you do a cholecystectomy, it looks the same whether you do it today or do it yesterday. You can modify it certainly, but the body and I think that consistency is crucial and important. You can't have an incomplete consent. You can't have something that's not applicable, so to speak. One of the things that we thought was tremendously helpful is the Spanish translation, for instance. We have a very high Spanish-speaking population, as well as we modified it individually, and I'm sure you're aware of it, of our interpreter and our ADA capabilities. So I think the one thing that you don't have to worry about as a provider is that it is a correct consent. And I think that really, once people saw that it was faster to create this, they were signed on it. The other group that really loved this was actually the nephrologists, because at 5 hospitals, dialysis consents could get lost. Okay. And this way, if they go to any 5 hospital at any time, the dialysis consent or a transfusion consent or a chemotherapy consent, you didn't have to search for it. We're on Epic. It's right there under the consent tab. It's completely integrated. It just, instead of searching in a media file for something that may or may not be found, okay, we knew it was always there. So definitely improve the workflow.
Awesome. Thank you. Dr. Fink?
Well, I would like to expand a little bit on what Dr. Coster just said, because not only are the forms already prepared and they're comprehensive, but they actually are much improved educational vehicles for patients. And we, as I alluded to before, but there's a large amount of literature involved showing the lack of comprehension on the part of patients. And I think these forms, particularly if you can disseminate them earlier, which you can now do, either we used to hand out printed unsigned copies to the patients to take home before they finalize their decisions. Great educational vehicle. I think that was very, very important. In addition, I think the other point that Dr. Coster raised that is central is the lost forms. Lost consent forms, unfortunately, are still a major problem in many facilities. Indeed, you mentioned Philadelphia. Well, down the road, it's a place called Johns Hopkins, where I went to medical school. And there was an article published exactly 10 years ago, 2013, with their experience. And believe it or not, 66% of the time, signed consent forms were missing when the patient presented to the preoperative area. Right. 66%. And that led to delays or cancellations of 14% of the operative cases. Think of the money that costs to an institution, let alone a patient gets all geared up, maybe even has a bowel prep or something, and then he's sitting there or she's sitting there, can't have her surgery. Let's see, one other thing that I think has been helpful to us in terms of safety is that, as Jeff mentioned, the form's right there, it's on the computer, whatever system you're using, but it became a formalized process where one could access the form and actually would do this in the operating room, pull up the form, and that would be one of the documents that was used in leading the timeout. That was all part of the operative procedure. And so I think that, lastly, I mentioned it's not a benefit to the patient necessarily, but to the facility, is a mechanism was built into the system that was one of the main reasons why the VA adopted the system they did, was the ability to automatically generate a progress note in the patient's record documenting elements of the discussion. That's mainly, I think, the primary reason why tort cases or malpractice claims disappeared a year after it was disseminated in the VA nationwide within the VA. And that's another thing that I think is beneficial to the institution, certainly at minimum. So
Great. So, Dr. Fink, I'm going to stay with you. Tell me a little bit, why do you think this informed consent process is the hardest to digitize in a health system today?
Well, I think partly because you're trying to digitize a process. You're not trying to digitize data. And that in and of itself makes it difficult. We can easily internalize various forms that are generic for one institution or another. But then the other issue is you got to fill it with content. And there are multiple elements of that content that need to be not only created, but they have to be maintained. And that's one of the biggest bugaboos why for facilities. They'll say, oh yeah, well, we can digitize it, we can scan our forms, whatever, but you've got to keep that content current. There's Mayo Clinic actually has their own process, but other facilities, we'll set up our system, but maintaining that library is problematic. Also, you have to be able to have a way to capture signatures, which of course have minimum legal requirements. And as Dr. Costa mentioned, you need to be able to customize it. While every cholecystectomy is the same, one surgeon may do it differently, and they want that description or that component of the procedure that he or she does differently to be incorporated in the consent form. So that has to be built into the digitized system as well.
Great. Thank you so much. Dr. Costa, one of the things that comes up kind of consistently with us, right, is what's the IT lift, right? What IT considerations do we need to consider? Could you tell us a little bit about IT considerations at Inova? How about the electronic signature component of it, the hardware? Can you give us a little bit of insight into how Inova looked at the IT part of this?
Sure, Doug. So I think that's really interesting. So one thing I wanted to add, though, to what Dr. Fink said in the back with the library, one thing I will tell everyone, the library is so comprehensive and it's updated so often that very rarely do you look at it and say, this is a ridiculous process. And if you did, Taylor has been really good about fixing that when we have things we need to add. I mean, in other words, we did our own anesthesia and blood products consent, and you guys were phenomenal in that. So
thank you. That's very nice to say. Thank you.
Kudos to you guys. So from the IT issue, it started from the beginning. Inova, like every health system out there, is hugely concerned, not being an IT person, with safety. So they wanted to be very concerned that we were safe behind our firewall. So yes, the server sits behind us, and the only time we go out to you guys is if we have a downtime, if we lose power and we can't supply our servers, and then we go out to you in our downtime application. But it goes as complicated to that is to the signature pads. So one of the big beasts we got in the signature pads on the WOWs was the cord's not long enough.
Yeah, right. Can't
So
reach.
actually, the cord was long enough. It was 6 feet, but we wrapped it around. The IT guys wrapped it around because they didn't want so much cord because they were worried the WOWs would roll over it. Okay. So we solved that very quickly, but not until we took the wow apart. We
Right.
did have some problems with our, initially when we went into this in 2018, with our connectivity. And then after multiple upgrades, that's long. In other words, just the data download from the wow to whatever the server was, it was just a little slow. We did try and do Microsoft Surfaces. We bought over 1,000 of them. They've been repurposed because that didn't work as a good workflow for us. The reason was we had to log in with our Epic ID to go through that. We had to go in a guest portal rather than directly with flash in, flash out to a workstation or to a wow. So we do not have the capability, for instance, on an iPad like process to have to have one card flash in. That would make that simpler, but those surfaces are repurposed for other means, so they got used within the system. But we thought that was going to be really neat and clean. Instead, that we kind of fell on our face with that. We did spend a tremendous amount of time on that, and it turned out not to be fruitful, but we found out in a good way. We did recently have an upgrade with our wows. We're that much faster, and I think every generation we go, we get, as our data speed gets faster and faster, IMED is faster. It's not slow by any sense of the words,
Right.
but certain areas it's a little lag. For instance, in radiology near the Emory tube, which is so well shielded, it's a little bit slower than other areas.
Yeah, interesting. Well, thank you. That's
let me-
great stuff. Go ahead, Dr. Fink.
Let me add one other thing.
Sure.
That, of course, becomes potentially problematic in terms of your devices, and that's the issue of cross-contamination, particularly if you're in a preoperative area and so forth. So I think that, as some people may know, Taylor's developed this new mechanism to disseminate the documents so people can read them, can review them, which is huge for education and comprehension, but also is good to allow people to digitize and return them without ever dealing with a device that is centric to the hospital or the facility, which I think helps in that regard as well.
I was going to be a good salesman and say that, Dr. Fink. So thanks for not making me be a sales guy. I was going to show you my phone and how you can just do it right on your device.
Yeah.
But thank you for that. I appreciate it.
So we're the beta
Jimmy,
site for that. I think we were the beta site for that, right?
You were. I know
Yeah.
it was. That's correct. I think you on the east and UCLA on the west.
Yeah.
But
And I
awesome
heard
stuff.
you're doing it in the VA now too. You're rolling
We
it
are.
out.
We are. They are
Yeah.
moving that direction. Yes. So give me a little bit about finding champions. You both said it's, the biggest thing that is to find people that really want to help you do this. Give me a little bit, and you could both go. I'll start, Dr. Fink, with you. Tell me a little bit about how you found champions. Did you target certain individuals? Like, give me like the perfect ideal person that we want to try and get on board early.
Well, I don't know that it's an issue of defining what the perfect person is or what characteristics, but I would bet that in the positions that Dr. Costas had and the ones that I've held, there's usually a very good chance you already know who those people are.
Right.
The people who have been concerned about patient care processes, those who are potentially involved in IT. You can always solicit it, but usually you have at least a couple targets right up front. And I think more importantly, once you obtain such individuals, and I'm sure Dr. Costa will have other attributes that he looks for, it's important, I think it's actually incumbent upon individuals in these positions like we were, at least like I was in those days, is to be sure they're well supported, or else the project's not going to fare well. So you need to be sure that you have appropriate IT support and ensure that the nursing staff is involved and knows how it works. And in addition, you need to have appropriate feedback with them about how they're doing, as well as feedback from the individuals running about what problems are encountered. And of course, in the VA, when it was made a performance metric, which it was, it became very, very helpful to some, painful to others, of having the metrics of, well, this section is doing so bad, or this one's doing so well. But that could also help move the process along. So, but I think compassion is always appropriate for the individuals to take on things like this. So.
Awesome. Dr. Costa, how about you?
Yeah, so Aaron, right on. I mean, I think one of the things that we definitely did is we cast a very big net. In other words, we tried to excite the people within the health system as to what this was going to look like and how cool this was and how it was going to streamline an otherwise cumbersome process, and it was better for patient care and safer, and really, was consistent with our mission, vision, and values. And we cast a very large net. I mean, there were certain people that you knew would jump on right away. But surprisingly enough, when you did that, there were some people who I was very, very surprised to step to the front and said, no, this looks good. This looks like something I want to be involved in. I do think nursing and support was crucial. IT was kind of back end, but I do think our relationship with nursing and getting strong nursing leaders, like one of the first things that we did once we decided we were going to go with Taylor is they basically have a meeting of all the CNOs across with the chief CNO, who was one of our triad leaders, and we presented to them, and we actually gave them an hour presentation on what this would do, and had them do consents with us. So, kind of had buy-in from the top down as well as the bottom up. But I think, once you show an exciting process and show how this is really the right way to do things, I think it naturally attracts a lot of good people.
That's awesome. Funny, because I sit here and I think risk and compliance and legal they'd be the champions, but it turns out like nursing, physician leadership, they're the best folks, it seems like, to get involved early and get on board early.
So risk and legal were key in developing, and they bought on right away.
Okay.
Yeah.
But I think, they sit in a corporate office. They're not in the trenches. So
True.
And I think you get buy-in when people believe in a process. And once people see this process a few times, they definitely say, this is the real deal. This is the way to move forward. And this is where actually digitization has helped the practice rather than hurt it. How many times do we hear with EMRs, oh, this is cumbersome, this is difficult, this is
Right.
There's no value added. There is definitely value added with this.
Well, yeah, then one other
Dr.
point.
Fink.
One other point, of course, I think that you're right, that legal and risk are always very strong champions for obvious reasons. But sometimes the biggest hurdle that I've experienced in various centers where I visited, or in our institution even, was IT, because it's a big workload and demand and a big project for IT. And that's often one of the most largest hurdles that have to be overcome to get acceptance and forward movement in this process.
Right. Awesome. So let's think about it from this standpoint. One of the things that comes up frequently, again, we talk to clients all the time, right? And the biggest thing they'll say to me is like, how efficient is this, right? Like, isn't this more work for the physician? Isn't this more work for the provider? And, it's hard, as a lay person, the sales guy, right? It's like to try and explain that it's a better, more efficient process, even though there's maybe more things to do. I'd like to hear from you guys, but let's start with you, Dr. Fink. What do you think about the efficiency of using a digitized, informed consent workflow?
Well, I don't think there's any question that it's more efficient. And the reason I say that is I remember when I didn't have access to this, and I was a youngster, probably more like your age, but
the camera must be playing tricks on you, Dr. Fink. I'm an old man. Look at that gray
see
hair.
if my glasses are still working.
Yeah.
But I would, when I did informed consent, first thing I'd have to do is take a blank form and I have to fill it out with the various elements on pre-printed lines.
Right.
That takes a lot of time right there. Secondly, to protect myself, and I would do this, but others didn't, I would then, when I was finished with my discussion, write a handwritten note in the progress note.
In the progress.
Today
yeah.
I met with, and we discussed this, here's the risk, that kind of stuff. That doesn't have to be done anymore with this process. And I think, and so that saves time. On the other side of the coin is the issue of comprehension on the part of the patient. I keep harping on that. That was the primary endpoint of that big randomized study that we ran back in 2006 or 2009 we finished. But one of the most important findings we found that the primary element that was most associated with successful comprehension on the part of the patient was the time committed by the care provider to the informed consent discussion. So if indeed you don't have to take the time to film the form out, you're gaining time there. And if you have something that can lead your discussion or that's been pre-read, that also provides more time that for a discussion and ultimately a true shared decision-making process that is also maybe even freeing up more time for you as a physician. So those are my thoughts.
Okay, Dr. Coster, how about you?
So efficiency is an interesting question, right?
Yeah.
How efficient is sitting in a courtroom because the consent got lost?
Yeah.
Yeah, good
Okay.
point.
So I mean, I think you have to look at what you really mean by efficiency. I mean, the most common cause for consents to not be compliant is legibility, right? And inappropriate abbreviations. Okay. It is very difficult, especially as more and more people use a computer, our handwriting gets worse and worse. So I'm going to bet that legibility score goes up, the illegibility score goes up over time. Okay.
Right.
I can fill out an IMED consent, and I know because in 15 seconds. Okay. I challenge anyone to do an informed consent front and back with proper laterality, legible in 15
Right.
seconds. Okay. The other thing too, and Dr. Fink is 100% right. What this consent process with IMED does is it makes you go through the steps of proper informed consent. Key being education. Okay. I mean, no one is going to look and read these 2 or 3 pages without having some questions, whether it's 2 weeks before the surgery or the morning of the surgery. So let's not talk about efficiency. Let's talk about efficacy, right? And you might not be efficient, but you might be very efficacious. Okay. And I think that I can show that this is time effective, that it prevents mistakes. It's the safest way, and it's a great educational tool.
Wow, that's a great tagline for our business. Thank you. So, Dr. Fink, I'm going to step back to you for a second. So, what do you think about the use of digital tools? How do they enhance the quality and comprehensibility of the information you're providing to patients during the informed consent process?
Well, ironically, I'm glad you asked that, because that was, as I mentioned, the primary and most important endpoint of that multiple facility randomized trial we did. It was the endpoint of comprehension on the part of the patient. Now, we wanted to compare paper to electronic, but we couldn't make that get that approved through the VA, I think because they had already committed to buying an electronic system. So we had to take the standard IMED and compare to an enhanced one. But one thing we did do was we did a very extensive survey of the literature where comprehension stood for patients. And obviously multiple forms, multiple technologies used, but we came up with a mean comprehension of 48% on the part of patients following informed consent discussions. When we then built that very rigorously into the tools we used in our randomized trial, and we found that even without the enhancement we had developed, the average comprehension on the part of patients went up to 66%. And when we added what was called repeat back, the tool with that, we got another couple percent points. So it was clear that there was a tremendous enhancement in comprehension. And I think we've talked about the things that maybe enhance it. You've got a form that's been vetted. You've got a form that's been prepared. Ideally, the physician has more time, the care provider has more time to spend with the patient to go over the discussion, which, as I said, was the element that was most important with comprehension. So I think those are all elements that have helped expand and improve the understanding. We can still do better, and there are other adjuncts that I know that Jeff is interested in and has mentioned, but I think those are worth considering as well. But I think we're making improvements. We've got a way to go, but I think we're on the right path.
And so just from a comprehension standpoint, you're talking about things like not using medical jargon, lay person kind of terminology, 6th grade, like give me a little bit, just kind of break down what comprehensibility means to you for the patient. Like, what are you trying to provide?
Well, I think they need to understand those elements, the critical elements. They need to know what's going to happen, why is it good for them to have it? Why is it bad for them to, what could happen bad to them?
Right.
What are the other things they can consider doing? And of course, what happens if they say no? Those are all the critical elements of informed consent discussion. And those are all elements that we tested for, but it's important a patient understands that.
Yeah.
And if they don't, they can't make an informed decision in collaboration with the care provider. And that's, I think, important. Tragically, one of the things that Taylor does as appropriate is that you target a reading level of 6th grade, which is the healthcare reading level of the average population, which does not necessarily speak well. But having done that, I think that also is an element that enhances comprehension.
Awesome. Great. Thank you. So just one more question, and then maybe we'll get to some Q&A and things like that. Dr. Costa, let's finish with you. So have you encountered any resistance or skepticism from the healthcare providers or patients regarding the shift to the digital consent, and how is it addressed at Inova?
So I don't really think that I heard anything from patients, and I don't necessarily know that you would see that unless they were probably in healthcare, right?
Right.
Okay. I think we initially always get a ton of pushback. I mean, one of the things, and you guys will love this, is my medical malpractice insurance carrier says I need to use this form, the one that I designed myself.
Yeah.
That was very simply is, okay, can I talk to your medical malpractice provider? Okay. And that never seemed to materialize. So I think, again, it was about change management. Okay. Right. And I think you had to prevent any smoldering from becoming big forest fires. Okay. I had one surgeon who was a general surgeon who said, this is slow and cumbersome, until I sat down with her and showed this is not slow and cumbersome. Well, I do these at home the night before, and I'm like, that's perfect. Right. Okay. So, and then, when we got the PDA where you could send the consent out. So there's a workflow that we use, and we actually send it to our patients ahead of time on their PDA, which they can read. And they can, we've talked to them about it in the office or in the hospital. Then they can, in the pre-op area, ask us questions if they so choose. I just think it's a very comprehensive package. The one thing that neither myself nor Dr. Fink mentioned is the drawings that you have.
Yeah, anatomical
drawings. And you could draw, say, for instance, it's a skin lesion, what the incision looks like to excise the skin lesion, or if you were going to do a flap, or where the incision is going to be. And additionally, you have anatomic drawings of the inside out, what this valve replacement looks like. The one thing I've been waiting for, and I'll jump the gun on that, is when we tag this to good educational videos.
Yeah.
Right? So, and I think that would be from a learning point of view.
Sure.
That's really where we want to go. To Dr. Fink's point, it's about education and patients actually knowing what is going to occur and why it's going to occur. And I think that would be the next step. This vehicle.
It's on the roadmap. I don't want to speak out of turn, but we're certainly looking at ways that we can incorporate video and education content into the process as well. It's something we can strongly consider investing in, and something we're trying to do as an organization. Whether we bake it ourselves or partner, that's kind of the next maybe iteration you're going to see as we kind of continue to improve the solution. Give me some final thoughts. One last final thought for everybody on the phone, if you don't mind. Dr. Costa, we'll start with you.
I think any of the people on this call are thinking about digitizing the consent process. I think it's a great initiative. I think it is so patient-centric, as well as a great benefit to the providers. It's quick, it's efficient, it's reproducible, and it's verifiable. So it does all the things you need to do, and it takes one big, from the administrative point of view, it takes one big headache, consent compliance, out of that wastebasket to another spot.
Awesome.
I think it improves patient comprehension tremendously. It encourages providers to spend time. So, I am very excited to continue with Taylor, and I think it was a great initiative, one that I'm personally proud of.
That's awesome. Thank you. Great recap. Dr. Fink, how about you? Final words.
Well, I think I'd like to maybe send a little suggestion to the people who are listening to this webinar.
Sure.
In things that we encountered in the VA as the first large organization that implemented this kind of a system. And we were fielding requests from the private sector multiple times about various individuals wanting to come and actually see the process, see how it worked, where it was a facility, it was in place and functioning. And I would just recommend that there are obviously many more now using this system than did back in the day. But by the same token, I think that's a wonderful opportunity to call colleagues at a different facility that have taken avail of the technology, see it and how it works, talk to patients. And this is a way to get, I think, down and dirty about how it works, what it can do, and address also the issues that may have been encountered, we've talked about today, and maybe raise unique circumstances that are also helpful. So that'd be a recommendation on my part.
That's great. I would add to that, just oddly, right? There's probably some physician in everybody's facilities that are on this phone that worked at the VA at one time and around, or at some point in their lifetime. You might want to go ask that physician.
The number is, it's said, I don't know if it's still true, I think it's pretty true, that at some point in their time, 85% of all healthcare providers have spent some time in a VA facility.
There you go.
85%.
There you go. Dr. Costa raised his hand. He has too. So there you go. Awesome stuff. How about any questions, Naomi? Anybody on the chat want me to address anything?
There's none yet, but we can give it a few minutes, see if there's any that come through.
Okay.
You know, it might be worth commenting also about issues about the library. And, you know, I oversee that for you folks, which is a very, very interesting process. But new documents that are drafted are reviewed by myself first and then it's sent out to independent physicians in the specialty to be reviewed. And that process is undertaken usually at least every 3 years for a document just to be re-reviewed, be sure it's up to date and current. Those are the kind of things that why healthcare systems don't want to take on maintaining a library, because it's so burdensome. And,
right.
You know, that's one of the great benefits of having someone do it for you, and you just take advantage of all that work.
Right. That's why we see so much traction in Texas with the Texas Health Panel and all the kind of laws that exist around that. So.
Yeah, so to that point, Dr. Fink, one of the things that was brought up when we were starting before the implementation is, what does the library look like? Who's on the committee? And, you know, so we had to download 1,000 of the consents and bring it through various subspecialties. Yeah. And they were, of course, trying to pick and choose what they wanted in there. But I mean, basically, they were very pleased with everything they saw. So, we've discussed this, but they always have the possibility to customize a specific form to their own desire. So that's another really nice feature about it, which I think enhances acceptance.
So I got a couple questions that came in from the group. So Katie Trapp asks, what is the average reading grade level for consents in the library? Dr. Fink?
6th grade.
So 6th grade is the average.
No, it's not the average.
It is 6th grade, sorry.
It's a target. It's a targeted reading level that we try to maintain in the documents. I'm not saying that we should be proud of that fact as on behalf of our country, but that is what is documented, I think, to be the current level of healthcare literacy in our country.
Right, and provided in English and Spanish too, Katie, for all consents. Yeah. My good friend Patty Burkus from Children's Hospital of Philadelphia. Has anyone ever counted how many clicks are required to start and finish an e-consent? Good question. Does anybody know?
I don't know.
No, I can try one right now.
I don't think it's
Dr. Costa's gonna knock one out real quick and let you know, Patty.
So Patty, I think it's probably about, for ours, so everyone can differ a little bit, but I think it's 9.
9?
I think it's 9, right?
I was going to say 10 or 12.
Yeah. And the only reason is it's laterality, right? And on ours, because we got dinged with something for ADA, so we have a little clause in there, which most people don't have. Whether you need a translator, who's signing, and I think it's 9.
Right.
But I would settle for 10.
Yeah. Somewhere around 10, Patty. Chop's so advanced, Patty, you guys can do it in 7. Don't worry. So there's no more questions from the group. I don't see any. Do you see any, Naomi?
Nope.
Oh, wait a minute. No, I'm lying. When consent forms are sent to the patients in advance, do they sign in advance? And if so, how do you account for the required witness signatures? Great question.
So the way that our policy reads is the witness actually can say to the patient, is this your signature? Did you sign this?
Okay.
But that's in our consent policy. I understand the question. So there was great consternation about what witnessing. So across all 5 places, witnessing was witness the signature, witness the consent, witness that the conversation happened. And all our witnessing is they can validate that the appropriate person signed the consent. Okay. Most of our staff takes that a little bit farther and wants to hear a conversation about that before they'll do it. And a lot of times we get some crosstalk back and forth, which is a good thing, right? That, you know, are you going to go over the consent with them? So it's a good thing. Yeah. But in our consent policy, all the witnesses is that they can validate that the appropriate person signed the consent.
And
Yeah,
Dr. Foster, correct me if I'm wrong, because she asked, do they sign in advance? If they don't sign in advance, you can save a draft. Is that
You
correct?
can. Yes, absolutely. Yes.
And I would add, Katie, what we've seen is it all depends really on the client's process and what their policies are. But with the advent of when COVID happened and a lot of the telehealth initiatives, so consent forms that may have been sent in advance and then a telehealth appointment was made, the consent, the verbal consent between the provider and the patient happened, you know, on a computer screen in essence, or a phone, and then they can sign and be witnessed that way too. So there's a lot of different kind of ways to skin that cat. And again, it goes back to policy and procedure for your health system. Okay, here's another good one from Katie. Do your physicians in their office outside of the hospital have access to the same technology?
Yes, because we use Epic and IMED is embedded in Epic.
Yes.
That's the case of most of the healthcare EMRs that are available. It's built as part of built right into the system.
So Cerner, Epic, yes, that everybody can, Katie. If you have physicians that aren't on the hospital's system, then it's a different workflow and a different kind of answer, you know, if they're not using Epic or Cerner or whatever the hospital's platform is.
Yeah.
Yes.
Doug, let me ask you a question.
Sure.
Can't you provide IMED as a standalone to small practices that are not using an EMR even?
I can provide IMED to anybody that wants to pay for it, Dr. Fink. But
a web, isn't it a web-based?
So we have a web-based PE solution. We also have a content-only solution where they can access the library, print it out on paper, sign and scan it. There's a lot of different, again, it all depends on the atmosphere or environment that they're in and what it looks like from a, you know, are they using Athena Health in the physician's office versus an Epic or Cerner, you know, those types
in the
of
hospital. Exactly right.
Correct.
Exactly right. Yeah.
Right, but the way it works within our health system, if you have privileges in Inova health system, you have remote access to Epic. So that means,
get out. That's awesome.
So that means everyone who's on staff, right, has
Yes.
Yeah.
So if they're in your network, we give them access. So that's accurate. Yes. Thank you. Okay. Katie, great questions. Patty, thank you so much. I don't see anything else. Thank you everybody for your time today. Thank you, Dr. Fink and Dr. Coster. As always, we really appreciate your support, and have a good day, everybody. Take care.
Great. Thank you.
Thank
you.